Good afternoon, everybody. It's 4 o'clock, and I'm going to give people a few minutes to trickle in. I'm just filling in for Thomas today, so I'm just letting everybody know. All right, everybody, we're going to go ahead and get started. So thank you guys all for coming to the weekly HiPAM community meeting. This is for December 17th, and I'm going to be filling in for Dr. Thomas Lee today. So we're going to be talking a little bit about the state of COVID, both internationally and locally here in the state of Hawaii, going over a couple of the different press releases for some of the new science out on COVID, and then going to be passing it off to a student from Dr. Marguerite Butler's lab to talk a little bit about the case study of COVID in California. So we're going to jump in and start talking a little bit about Japan here. So as we've talked about in the past, Japan does continue to see a slight uptick in its COVID cases. However, I did look at the amount of travelers still coming in from Japan to Hawaii, and while they're allowed to come, the percentage of people coming versus the previous year is really low. only about 3 or 5% of the total of Japanese travelers coming into Hawaii this year are coming. So even though it is continuing to spike in Japan, it is a relatively low number of Japanese travelers coming into Hawaii. So we will continue to watch this as this may continue to rise, but just wanted to make everyone aware of that piece. Nationally, the US is still looking to be in a pretty bleak pace. As you can see at the top of the curve here, it's possible that it's leveling off, but you really can't be sure at a moment in time like this. The whole US is pretty much red and the case counts are rising still pretty dramatically. And now the hospitalizations and the ICU numbers are also catching up to all of these recent spikes as well. So a lot of places are in a really critical condition. One thing to note is that it does appear that some of the initial outbreaks in the Midwest are slowing down slightly compared to where they were. They're still in a really bad place, but it seems to be shifting more towards the western and eastern parts of the states. So there is a snowstorm now in the eastern part of the US. So it's possible that will prevent people from going outside. So maybe we'll see that slow down on a little bit over the next week or two, but still looking to be in a pretty difficult spot for a lot of places in the US. And as we drill down into some of the states that we know have a lot of local visitors and residents living there, looking at places like Arizona and California. And again, as I mentioned, a lot of these COVID cases really are spiking in the West. So Arizona and California both seeing double-digit increases, both seeing that their hospitals and ICU strained and probably will continue to do so, even more so in the next coming weeks, just based off of the rising trend over the past couple of weeks. So still in a really difficult position as we enter the holidays. And this holds true through some other states as well that are popular destinations for our residents and also previous residents, Nevada and Texas. Still going up, these states might be slightly hitting their peaks, as we can hope for that, but they're still not out of the woods yet by any means. And again, these hospitalizations are catching up to all these rising case counts. So it's still in a pretty dire position as we enter the holidays for both of these states. And when we look at Hawaii specifically, we're still hanging on okay. We have seen a rise in case counts over the past couple weeks, seeing our 7-day average rising and our positivity rate jumping up above the 3% line for the first time in several weeks now. It's still, while we are increasing, we're not at any kind of critical level yet. We will continue to monitor this as we are, again, kind of on the precipice of seeing an increase. And if it becomes to the point where it's out of hand of our current contact tracing capacity, we might see an even further increase in the coming weeks. So how does this translate? The testing turnaround time, the piece that we like to continue to iterate upon, it does seem to be improving at least very slightly over this past week. Still seeing about 3/4 of the test turning around in one day, which is really good. And it's going to be extremely important as we continue on. And if we do continue to see these rises, having these fast turnaround times are essential for making sure that we can quarantine and isolate people as fast as possible as they get a positive result. So looking at the forecast, again, we are seeing diverging lines for our pessimistic, which is the red line, and kind of our more expected scenario. Our expected scenario is still holding around a 1 RT, just based off of the fact that we have seen some rises and falls in the overall 7-day average over the past several weeks now. So hopefully that this current peak does shift back down. But if it continues to rise at current levels, we will start to see a significant increase in the case amounts and a relatively significant number in adds to the hospitalizations and the ICUs over the coming weeks. Again, hoping that this stays in the expected realm, holding flat around 100 cases average per 7 days. But it's possible that we get into the 130, 40, 50 by the end of the next 2 weeks if things don't slow down at all. And by that point too, we're close to be seeing triple digits in the hospitals as well. So again, it's hard to say at this point, but this is where we could be heading if trends don't change in the future here. So looking at this from a raw numbers perspective, the pessimistic does look relatively dramatic in the fact that we're going upwards of 50% for the cases and the hospitalizations rate. Again, these numbers are relatively low from a raw standpoint. We're currently at 125 cases per 7 days, around 60 hospitalizations, but that still is a meaningful increase. But really hoping that we continue to hold flat over the next 2 weeks, and we hold more in that expected scenario of around 100 cases per 7 days. And a few pieces of science that we wanted to highlight over that have been recently released. One is a over-the-counter antigen test, and the next is talking about the vaccine rollout and some of the potential negative impacts, or I guess the lack of reach in other parts of the world. So starting first with the over-the-counter antigen test that has now been approved by the FDA. So this is really exciting. It's a test that is going to be available to be over the counter and also completes in 20 minutes. So it's something that someone can take at home without the necessary prescription in order to complete it for themselves. It's just a nasal swab. It's not as deep as the PCR tests that are administered in a hospital, but it allows for people to be able to do it for themselves, and it's going to dramatically increase our testing capacity and make it a lot easier for people to actually self-administer. And it's still a relatively sensitive test. It is not as sensitive and accurate as the PCR, but it claims to have, when people have symptoms, it's still a 96% positive rate and identifies 100% of the negative results. If someone is asymptomatic, this drops about 5% in the other direction. So it's still relatively sensitive, but not quite so as we're looking at the PCR. So it's still important for us to think about, how these tests interrelate with the PCR and these antigen tests, so that people aren't necessarily taking these antigen tests as gospel and trying to use them to get on flights and things like that. But wanted to make this broadly aware for people, because this is a significant piece for us here moving forward in the COVID race. So the other piece of science we wanted to highlight is thinking about the vaccine and access for some of the lower income nations. So as we continue to roll out for the US and continue to have a lot of vaccines on pre-order, most of the pre-orders for the vaccines are going to be coming from the rich countries. When we look at some of the lower income countries, it's likely that they won't be having a vaccine until at least 2022, and that's for nearly a quarter of the world's population. So it's pretty significant when we think about needing to have a large piece of the global population immunized in order for the vaccinations to be truly effective. So this is going to be really critical for us as we continue to try to mitigate this from a global standpoint. Also overlaying that, we have to understand that only about 2/3 of people right now are saying that they're willing to accept a COVID vaccine. And when we look at studies that were done even by the University of UH Manoa, looking at the beginning of the pandemic versus now, the number of people that are willing to take the vaccine appears to be also going down. So this is a significant hurdle as we think about moving forward here. So even in 2021 and maybe even in 2022, physical distance and mask wearing are still going to be essential mitigation steps as we continue moving forward here. The vaccine's not going to be a panacea, within the first few months of rolling it out. There's still a lot of significant supply hurdles moving forward. So there's a lot that we have to think about moving forward in 2021 and even in 2022, because even with the vaccine rolling out, there's still a lot of questions that come into play when it comes to the long-term efficacy of the vaccines and if we need to have even more than one dose right now. So a lot of questions that are still kind of unanswered about this, but wanted to kind of highlight, outside of the scope of just the US, because it's really important as we look at this as obviously a global pandemic here. So I've been talking a lot. I just wanted to look at the chat quickly to see if we have any questions here. And one of the questions is, do you have any thoughts on separating inmate data? And that's a really good question. And this is going to be related to the COVID forecast for the state of Hawaii. I would like to do that. We don't quite have the granularity of data. The report for the cluster data is uh, is uh, is good data for us to be looking at on a weekly basis, but it's still difficult to actually predict how it's going to necessarily translate to the outside community, because the reality is that there's still people that can be taking the virus outside in the community and have that spread that's going to be creating some kind of new event. So it's still has a potential for community impact. But I know I do understand what you're saying, because it's still, I think 70 to 80% of the cases right now are in the correctional facilities. If I'm not mistaken, apologies if that's a little bit high. But it's definitely something to take into account as we're looking at the forecast, but it definitely doesn't mean that it's not going to impact the community in that regard. And Josh, you asked about how will we know who is infected if people are doing home tests. That's a good question. I don't have a good answer to that piece. I don't know if anyone else has an understanding of the implications for the at-home test regarding that. I think it's more for people to self-administer to understand if they need to quarantine by themselves. I don't know how it's going to translate to case counts that's going to be reported up the chain. Does anyone have any other questions related to any of the highlights or the forecast for this week? Okay, I'm going to go ahead and pass it off to Ethan Hill, who is part of Dr. Marguerite Butler's lab, who's going to talk about California as a case study here and tracing COVID with genetics. Ethan, are you live?
Yes, I am. Hello. Can everyone hear me?
We can hear you.
Perfect. And do I have the ability to progress the slides, or?
I'm going to be doing that for you, so just let me know when you want me to move forward.
Okay, perfect. So, hello, again, everybody. Oh, wait, yeah. There we go. Hello again, everybody. So today I'll be presenting tracing SARS-CoV-2 with genetics using California as a case study. And California has experienced an extremely large outbreak of COVID-19 cases. And as we've seen recently, especially in LA, it's getting worse and worse. And the interesting thing about California is that confirmed positive cases in California, they've been collecting genomes and sequencing these genomes starting in March. And along with just the patient or the SARS-CoV-2 genome from each patient, they've actually been collecting location data about where these samples came from. And what I wanted to do is do an example analysis to show the power of a phylogenetic analysis that combines the history of the SARS-CoV-2 virus along with the geographic information. Because what we want to do is apply something like this to the state of Hawaii so we can have a better understanding of how the virus moves through a population and also supplement contact tracing efforts in case things get especially bad. So we can advance. Perfect. So some background. California is experiencing, they're experiencing a huge outbreak. I mean, just in the past couple of days, they've been looking at about 30,000 new cases per day. And right now their total is about 1.5 million cases. And their deaths are increasing as well. And I want to remind everybody that California is a travel source as a large travel source coming to Hawaii. So the number of cases there is related to us. Now, like I mentioned earlier, if we can progress, California has been collecting. Oh, could we advance the slide, please? Perfect. Yeah, so California has been collecting geographic location for each of the samples, for each of the confirmed cases, and for the genomes that have been sequences geographic locations of those. And we can see that there are particular hotspots in California. So in the Bay Area, we can see the number of cases are fairly high, as well as in Southern California, which is blowing up. Now, if we advance, I have collected, or I've downloaded 570 genomes that span over 16 counties in California. And here's a map giving you an idea of where these genomes were collected across the geographic region. So it's a pretty good spread across California. And to give you an idea, just a quick refresher of what's available from these genomes, if we could advance the slide. The SARS-CoV-2 genome is about 30,000 bases long, and it roughly averages, and it mutates fairly quickly, which roughly averages to about 1 unique mutation per transmission. And we can actually use these mutational information to trace the chain of transmission through a population. So if we can advance the slide, in addition to just the mutations that we have, we can pair that with the geography. And from this, we can infer the origin, the timing, and the spatial dynamics of the chain of transmission through a population. The data going into this model are the sequences themselves, the SARS-CoV-2 genomes, and the geographic location where they're connected. And we are only limited, honestly, by the amount of input data that we have. So the greater input data we have, we can get better resolution in these analyses. So this is what a phylogenetic tree, a family tree of all the SARS-CoV-2 genomes, the 570 SARS-CoV-2 genomes that we collected from California. And it's extremely large, but we can, I'll break it down for you so we can actually look at the important things. So if we could advance the slide. So this is going to be some summary from the, similar to the past presentation. So we can identify the origin, or the timing of origin of SARS-CoV-2 in California, which places it back in mid-December, according to this analysis. And if we advance the slide, we can see that there were 4 clades, or 4 lineages of SARS-CoV-2 circulating in California. And if we advance one more time, what we can actually see is that 2 of these 4 lineages have gone extinct. So currently, it looks like there's only 2 main lineages of SARS-CoV-2 circulating in California. However, if we go over next, can we identify the chain of transmission using this sort of information? And we can model this a couple different ways. So if we go forward, we can cut up California into different size geographic regions. So we can look at this on a county by county basis, or we can cut California up into large geographic regions and see which of these geographic bins explains the pattern of spread the best. In addition to this, we can also look at the different ways that SARS-CoV-2 is spread throughout these geographic regions. So we can look at whether or not a model that accounts for only adjacent region dispersal. So if one region is infected, the only regions that can be affected are those regions that are immediately adjacent to that first region. Or we can look at potentially long distance dispersal events. And in this case, long distance dispersal events connect 2 non-adjacent regions and would represent travel. So what we basically found is that the county, breaking up California into counties and applying an adjacency model was the worst fit so far. The next worst fit was a county, if we could advance. The next worst fit looks at county versus and long distance together. Next was the geographic bins with the adjacent model applied, and the best fitting model by a long shot was splitting California into 5 distinct geographic regions and accounting for long distance dispersal patterns. Now, what you'll notice interestingly about this data is that regardless of region or county geographic bins, what we see is that the long distance dispersal that accounts for long distance travel consistently scores better than any sort of model that accounts for only adjacent movement between neighboring geographic regions. So what does this all mean? What we can actually conclude from an analysis like this is that the SARS-CoV-2 pandemic started in San Diego. And I want to show you a time progression of how we can actually trace these transmission lineages through time. So what we can see, and I want to pull your attention to the bottom right corner, This is going to be the timeline for the infection for the parts of the phylogenetic tree that I'm showing you and their relationship to the point in time. So what we can see is that in like late March, early April, SARS-CoV-2 started jumping out of Southern California. And if we go next, oh, sorry, if we go back real quick. And what we can see too is those first jumps occurred from Southern California to Northern California and Southern California to the purple, which we've been calling coastal California. And this happened fairly early. At the next time point, which occurs in about mid-April, what we see is movement from the coastal area of California, a long distance dispersal all the way up to the top to Northern California, as well as movement from the coastal region into the Bay Area and into this Central California. And if we progress one more time, we can actually see that in mid-May, there was yet another introduction into the Bay Area from Central California. And I just want to remind everybody that in this tree that we see on the right-hand side, every single one of these tip labels represents a person, and each one of these dots represents a connection between two people. So we can actually see these two people and how they're related and how their virus is related. And we can use this to infer chains of transmission. So if we go forward to the next slide, what we can see is that there's a second wave of infection that's coming out of San Diego that also occurred in March. And we can see that this wave is slightly different. So out of San Diego, we'll notice a long distance transmission from San Diego to the Bay Area, as well as from San Diego to, again, central, as well as coastal California. And if we progress one more time, what we'll also notice is that from the Bay Area, it went back into Central California. And finally, what we noticed is that in May, so after that initial wave went out of Southern California and into the Bay Area, we'll see that it's actually coming out of the Bay Area again. So what we'll see here is from the Bay Area, it went up into Northern California, as well as down into coastal, as well as down into central. And what we'll also see too is that it actually went from central back into the Bay Area in early June. And I want to emphasize that there is a lot of back and forth in these models because it's just going everywhere, and the traveling, especially the long distance traveling, allows it just to spread back and forth between larger georegions. All right, so now we can look at starting to look at the finer details. So for example, we can actually look at how community transmission occurs in certain regions. So in late July, mid to late July, there was a huge spike in cases that we saw. And we can actually see that sampling from these cases, especially in Northern California, specifically Humboldt County, was represented in the tree. And we can see that there was potentially an introduction from San Joaquin, so that Sierra area of California into Northern California, and then it just spread through the population. And remember that each of these tip labels is a person, and each one of these dots is a connection between two people. So if we were to trace this back through the tree, we can potentially see who got the virus from who, and trace it all the way back to until the point of introduction that we can see was potentially from San Joaquin County. And we can continue to do this for different community outbreaks. So here's another outbreak that occurred in Alameda County in September. And what we can see here is that in Alameda County, it looks like they got their virus from Madera County, so from central into the Bay Area. And then within a relatively short amount of time, it just exploded everywhere. And you'll notice that all these sampling dates were very close to each other. And if you look at the clustering of dots in the tree, they're extremely close to each other, which means that this particular community transmission occurred very rapidly. Now, we can also zoom in a little bit more and see how, say, within the Bay Area, SARS-CoV-2 is transferred between geographic regions. And this is going to be an example from May. So I'm going to zoom in on the Bay Area so we can just look there and see what's happening. And what we can see is that there is a whole bunch of transmission between adjacent counties. So all of this, so this cluster of infections in this area occurred in late April, early May. But what we can see is that there is not a chain of progression. There's not like stratified points along the tree in this particular section. What we see is a whole bunch of points that align with one particular point in time. And what that basically means is that all of this transfer, so the transfers between San Francisco and Contra Costa, between San Francisco and Alameda, between Contra Costa and Marin, this is all happening around the same time. And it's happening very rapidly. And and in the Bay Area, a lot of people commute into San Francisco, out of San Francisco for work. So we know that even these local patterns of commute, these local patterns of travel, really heavily influence how widespread and how widespread the virus can get in a geographic region. And it just becomes a melting pot. And finally, what we can see too is that from San Francisco, one more thing on the last slide. And what we can see too is from San Francisco, we can actually see it hop out of San Francisco into Madera County and then back into Marin from Madera County. So there's a whole lot of transmission going on in a relatively small geographic region. So with this sort of analyses, if we applied it to Hawaii, if we were able to get the samples, we could definitely see, identify imports versus community transmission extremely easily, and we can use this to inform the effectiveness of our travel regulations. We can also use this, as you can see, to infer transmission lineages, not only through time, but especially in dense clusters of super spreader events in the community. And the only thing that we're limited by in these sorts of analyses are the number of samples that we have present, or the number of samples that we include. Finally, we can identify and trace the hotspots of community transmission. So if we know that a pocket of community transmission occurred on this day, we could eventually trace it to not only an event, but the people who attended the event. And then we could see who got the virus from who. And we can also see, or we can also inform people potentially where they got infected, so the geographic region. And I do want to emphasize that all of this is possible with good sampling. So the more samples we have, the better resolution these analyses can return. And also, these analyses are particularly fast to do. The turnover time for these analyses are less than a day. So we were able to reconstruct this model on a daily basis as more samples come in. And we're really excited to give this a shot for Hawaii. So finally, with that being said, I think I have one more slide. Thank you so much for listening to my talk. And as a heads up, we currently are looking for Hawaii sequences samples to sequence for a whole genome sequencing, so we can conduct analyses like this. And I would like to open the floor to questions, but specifically, I would like to open up the floor to questions from anyone who is in public health, wondering like what sort of information they would like to see in an analysis like this, or what sort of information they would like to gain, or any suggestions that they would have to make this sort of analyses even more powerful, or how policies could be adjusted. On that note, thank you. And I will be taking questions. Let's see. So is there anything? Oh, so a question from James Raymond. Is there anything in the genome data that actually pinpoints the type of activity that results in transmission, so that policy could be adjusted? So unfortunately, that sort of data I don't believe can be extracted from the genome. The genome just mainly looks at mutations and how we can use those mutations to trace it through the population, but not necessarily the type of activity. But we could definitely see correlations between large gatherings or any sort of activities like that, and the specific lineage of the virus that's present. So for example, if you had a bunch of people at a particular event and they all come down with COVID-19 and you sequence the SARS-CoV-2 genome from them, and you see that they're all related, you can conclude that all these people were at this one event and someone or multiple people just infected everybody at that event. Can you triangulate with, oh, sorry, so yes. Any other questions? Like a bingo, yeah, exactly. Or like a bygone event, yeah, biogen event, yes, yes, yes. So Joshua Quint has a question. Oh, I can check the Q&A, yes. Thank you for reminding me. So how would you use genetic sequencing to evaluate the role of travel in community transmission? Oh, this is a really, really good question. So we can actually see, based on the geographic data, and we would have to include some travel history as well, but we can see where the genomes are coming from and how they spread in the community. And it would be relatively simple just to identify, is this coming in from, say, a place like Japan versus a place like California? And then we would be able to basically see how that's propagated in the community. And in order to do that, we would need to first include more sequences and include international sequences and have good sampling from a lot of different countries, and also increase the sampling in Hawaii too, so we can see whether or not the infections in Hawaii stem from other regions. Because I believe currently there are only 12 published genomes that have come from Hawaii, and I believe all of these were sequenced back in March, and they were just released within the past 2 months. So we're starting to increase the number of samples here, but we would definitely like to really increase the number of samples here.
Oh, Ethan, if I can just add to that.
Yes, of course.
So if you sequence something that came from Japan, actually, what will happen is that sequence will be outside of all the Hawaii sequences. So it'll be obvious that it's from somewhere else. And then if you include Japan sequences, that sequence will be right in the middle of those. So they definitely have a genetic signature that you can easily locate to travel.
Oh, thank you for that clarification, Dr. Butler. Let's see, what else? Okay, so did you, so from RP, I'm sorry, I don't know. But yes, oh, so sorry, the question is, did you compare these sequences data to sewage monitoring? So with the data set that I had for this analysis, I did not include, or I didn't specifically include any data from sewage monitoring. I only included data from or nasopharyngeal or oropharyngeal swabs. Okay, give me a second as I look for more questions. Could you use this data to find the true source of origin? Yes, yes, we could. And like Dr. Butler had just mentioned, a sequence or a genome from Japan would have a unique genetic sequence, and all of the down the line transmissions of that original infection would share a similar genetic makeup or similar genetic sequence to that one from Japan. So in theory, it would be very possible to find that and fairly easy to identify. Back to find original source. Yeah, that's what we intend to do, especially when we start looking at travel and we note where the travelers came from. It will be very, very easy to see where those SARS-CoV-2 genomes originated from. Perfect. Are there any other questions?
You have one more comment, I think, from Joshua.
Oh, yes. Oh, thank you. Joshua, yes, I'm thinking about tracing community infections, cases that had no travel history or contact with someone with travel history. And so would have originated elsewhere compared to Hawaii. Epidemic true community sequences. Perfect. That sounds great. Yeah, and I mean, an analysis like this would help with that so a lot. And like I showed with the last slide, not only between like large geographic regions, but we could even get to the point where if we know where on, say, Oahu or where on the islands a particular sequence came from, it would be very easy just to follow back the chain of transmission and see who gave it to who or where it originated from. Yeah, and we could do this at different scales. It's extremely scalable.
Yeah, it's really about sort of logistics and coordinating, I think. If it could certainly be coordinated, because, for example, I believe in Australia, they are now sequencing every single positive, right? So, so that would be amazing. And it would be great to partner between academic and public health labs to figure out, you know, how we could best serve the community.
Definitely. Oh yeah, and that's a great comment, Joshua. People lie, people have bad memories, but genetics can tell the entire history of the virus. That is completely true. Like if you get a sample and you run it through an analysis like this, it will tell you exactly where it came from. So yeah, you don't have to deal with you know, any of the potential inaccuracies of people. Oh, Dr. Butler, I believe this question is directed towards you. What is the state of sequencing the virus in Hawaii, and why are there only 12 samples?
I don't know. Ethan might know better. I mean, I know. Yeah, go ahead. I know that the first 4 were from the CDC, right?
Yes.
Ethan?
Yeah. So why only 12 samples? I'll start with that one. That's a good question. I don't know. Those are just the ones that have been released to the public. Of the 12 samples, the first 4 of them were sequenced by the CDC, and these were samples that were collected back in March, and I believe they were published in June. The remaining 8 were just published back in October, and these were done by, I believe, Quest Diagnostics. So it wasn't done by the CDC, it was done by a private company.
Yeah, and I have contacted the state testing lab, and they said that they're working on sequencing. But yeah, we're just trying really hard to establish collaborations and, you know, trying to see how we can work together. So I'm not quite sure what's going on. And I think that also the UH CLIA lab has started and they've sequenced 2, right?
But yeah, I don't believe those have been published yet.
Yeah.
This is Josh. I was just promoted. I was chatting in. Thank you so much. I've been asking some of these same questions about, because my background is as an undergrad as an evolutionary biologist and then gravitated towards epidemiology. So I miss seeing the sequencing and the clades and all that. Really great explanations, and thinking about how much we could learn, and sequencing technology is pretty straightforward. And so I'll maybe look into my end of what the state lab is doing and how we can maybe collaborate. This is awesome.
That would be amazing.
Thank you.
Yeah, because I mean, I think it's something that the state could do, and it's something that some of the other studies that have published, the academic studies have published, that these are definitely scalable and with coordination could become part of a public health workflow, you know, so like the academic labs can work out some of the like, well, gee whiz, what if we do this or what if we do that, you know, and then it can hopefully become part of some helpful protocol or something. That would be fantastic.
Perfect. Another question from James Raymond. Could you discuss other local countries that have made use of this tactic? Yes. So Brazil did a study very similar, or did a study kind of similar to this. It was published in Nature, I believe it was back in June. But what they did was they looked at the different waves of SARS-CoV-2 across their country, and they were actually able to link it to air travel. And what they found was that during the first wave of the pandemic, everything came into Rio de Janeiro from international sources. And And then in the second wave, or so came into Rio and then out to the rural areas in the first wave of the pandemic. And then there was a dip. And then in the second spike, what they actually found was that from the rural areas, it was coming back into metropolitan areas. And they're able to identify this based on flight records as well as geographic location from the sampling. And then I believe the UK did something similar, and they were identifying how many introductions were in their country. And to summarize briefly, what they found is there was no true patient zero for the UK. They actually identified thousands of introductions over the course of a couple months. And it was surprising because I guess a lot of people in the UK thought that this was like a patient zero type situation where they had one person who introduced it and then it just propagated within the local community. Whereas what they actually found was a whole bunch of introductions. And that's purely because of travel. A lot of it is travel related.
Yeah, but I think that people are thinking about this as a useful technology, especially for places like ours that are far away from big centers and where we might, sometimes exceed contact tracing capacity, but yet we have labs, so this is definitely a supplement for other sources of information, hopefully.
Can I ask a question thinking about more broadly, like viral genetics? Is that fair game? And maybe no one has the answer, but just has there been any progress or insights onto variants in terms of like severity? And is there any attenuation or any of that going on? Or I remember early on there was interest in this. How is this will it evolve and change? What's the mutation rate? And thinking about, and early it seemed like, the mutation rate isn't fast enough to generate a lot of different, like higher virulence or lower pathogenicity strains. So has anything been going on in that? I'm outside of the world of the academics and the papers, so I appreciate this group filling me in.
I believe so. They've done research. Mainly, what they've been mainly looking at is the link between transmissibility and a particular mutation in the spike protein. What they found is that in position, I believe it's 614 in the spike protein, a base pair from, I believe it's an amino acid change from D to G, is often corresponds to or is sampled highly in areas that have experienced increase in transmissibility. Actually, my lab mate Claire Fraser is looking into links between particular genetic sequences and the infectivity, transmissibility, and mortality of the different mutations.
Thanks.
Yeah, I don't know. Claire, do you want to jump in, or I don't know how to let Claire talk?
Hi, can you hear me? Yeah.
Yes.
So yeah, like Ethan was saying, with that D614G mutation in the spike protein, they've noticed that there's it's increased transmissibility by 10 times. So that's one mutation that they've noticed has actually swept across the whole globe, and it's now that variant is the only variant that exists at that position. So I'm kind of looking into exploring different types or different mutations that occur that actually might cause changes or might have some links to mortality, and just to see like if there are differences in the way that the virus is evolving in populations that vary in mortality. But yeah, there's a lot of work going into it now, so it'll be interesting to see kind of what everyone finds.
Yeah, it's a very shockingly huge effect of increasing transmission, but so far it doesn't seem to affect mortality. So I mean,
oh yeah, I was just gonna say in general, from what I remember of kind of viral genetics and dynamics, there's a predisposition to become more transmissible and less lethal because that will promote the spread of the virus. And you would need usually some kind of like a major genetic shift or a mixing like we see with influenza, where you can have hybridization that's like a rare event to suddenly increase mortality.
Perfect. Thank you so much. Let's see, what else is there? Are you using this Sphere program? Oh, so from the CDC, I have not used it yet. Let me take a look. And I currently do not know if Hawaii is currently part of the Sphere program, but I'll definitely look into it. And the advanced. These look like great resources. Thank you for posting them. But yes, I'll definitely look into this and see if we can incorporate data or funding from these agencies to continue this. Let's see. Oh, have you looked into the different potential side effects of the lineup of vaccines coming down the pipeline? Oh, looks like Pfizer, Moderna are similar, but not much news on the follow-on types.
That's outside of our.
I believe that might be a bit outside of my area.
I don't think we have Andrew on, who'd probably be the person to answer that, and because that's outside of mine too. So Tom, I don't have a good answer to that.
You are our closest crew here.
Close but no cigar, I'm afraid.
We're trying. So given the rate of mutation, is it possible to predict when certain vaccines may no longer be effective? So this is an interesting question. So the mutation rate is, it's fairly quick, but the part of the virus that the vaccine is targeting is a spike protein. And to our understanding, the spike protein has remained relatively conserved because it's a lock-and key mechanism. So it needs to maintain its structural conformation in order to be as effective as it is. That being said, just because we haven't seen it yet doesn't necessarily mean we're safe. But just judging by how specific the spike protein is to the ACE2 receptor is, we wouldn't expect too many we wouldn't expect a fast rate of mutation in that site.
Yeah, the ACE2 receptor is a receptor that we have all over our bodies, and particularly along our respiratory tract. And that's the keyhole that the virus uses to get in. And so it can't really mutate that portion too much, or else it won't work at all. So that's the hope. But the really amazing thing about these new mRNA viruses is if that actually does happen, they could pretty quickly turn around and create a new vaccine.
Definitely. Perfect. I believe that was the one in the Q&A. Perfect.
Any other questions for the crew, for Ethan, for Dr. Butler? Great. I think we can go ahead and wrap up then. Ethan and Dr. Butler and Claire, that was really wonderful. So I really appreciate you guys taking the time to share today. So thanks for all your hard work. If there's not any other questions today, we can go ahead and wrap up the session. Just give it one more second to see. But I want to thank you guys all for attending, and thanks for the work from the team. So we'll see you guys all next week. Thanks all for joining.
Thank you so much.
Thanks, guys.